Good morning, good evening, wherever you are in which part of the world. I think CCI is now global. So good evening to everybody in India, to colleagues, clinicians, to postgraduate students, and all the respiratory physicians and general physicians who are waiting to gain knowledge from this webinar. Thank you for joining in. Thank you for being here. Thank you for encouraging us to read more and deliver more good lectures and webinars, programs like this. I thank the entire CCI team, Dr. Vijay Kumar, Dr. Krishna, and Dr. Shivani, who were instrumental in bringing me here at this point of time in this platform. I am really privileged and honored to be here among this elite group of physicians who are ever eager to read. Thank you so much for having me here. Today, I think today is a very, very interesting topic which I think all of us face in our day-to-day practice. Such a common clinical topic, but often overlooked. We don't even discuss this topic, and most of the time guidelines are also not enough to discuss this topic. So this topic is about COPD patients traveling high altitude and what you do with the oxygen requirement, and how you answer all your questions to a COPD patient who wants to travel or who wants to climb Mount Everest or whatever he wants to do. What will be or how will you face these patients in your day-to-day clinic is what we are going to discuss. So today we are lifting off to a topic that is often overlooked but increasingly very, very critical in modern respiratory care. Why I say this? Because air travel is so common, and all COPD patients, they are not even assessed or not even, they don't even come to us to say that we are going to travel. Please give us permission, what precautions we should do. I think very, very few patients come to us out of anxiousness, but most of them do not even come to us. They just travel, and you would have seen across the globe, there will be flights which are, the journey is cut short. They are just grounded just because of medical emergencies, and it costs a lot of inconvenience to the other travelers also. So I think it's such an important topic. We have about 250 million patients who are affected COPD globally, and air travel is becoming more and more common, especially in the aging populations. And across the globe, Indians travel to various other continents, countries, to different altitudes, different climates, different zones. So I think I am also very, very curious to look forward to this panel, elite panel on discussion and how they manage their patients. I think all of us can learn more from all the eminent panelists here. I think at the start we have let me introduce my team here. So we have Dr. Pramod, Dr. Deepthi Krishnan, Dr. Sudarshan Pothal, and Dr. Anand Vardhan. All of them are really stalwarts in their own practice in different parts of the countries. So you are going to hear from what their view is about in COPD patients and how you can advise them. So we have an eminent panel, and before we really get into the panel discussion, we have two short talks by Dr. Deepthi on flying recommendation in COPD, followed by Dr. Anand, who's going to speak to us on higher altitude and what happens to COPD patients in higher altitude. I think let me invite Dr. Deepthi for her short and sweet talk on gist of flying recommendation in COPD. Dr. Deepthi, over to you.
Thank you, Dr. Thilagavathy, for that kind introduction. Let me begin by thanking Dr. Krishna, the CCI team, the webinar coordinator, Dr. Vijay Kumar, for giving me this opportunity. I have been asked to speak about flying recommendations in COPD. So we should be aware that the in-flight medical emergencies are estimated to be almost 1 for every 600 flights. And the most common ones being syncope, gastrointestinal, respiratory, and cardiovascular, which puts us third in the list. So the topics to be covered here are the physiological impact of air travel on patients with COPD, pre-travel risk assessment, and prescribing portable oxygen devices during the travel. Ordinarily, flights reach an altitude of almost 25,000 to 45,000 feet above sea level. But according to international laws, the cabin pressure must not surpass 8,000 feet above sea level. And when a study was conducted on 240 flights, it did appear that the pressures were between 5,000 and 8,000 feet per above sea level. So, what really happens in such pressurized cabins? There is a decrease in the barometric pressure from 760 millimeter mercury to 565. A decrease in the PiO2 from 150 to 110. The FiO2 comes down from 21% to 15%. The PaO2 from 100 to almost half, that is 50. And the saturation falls from 99 to 91. Such a hypobaric hypoxemia can precipitate respiratory failure. And if there is a gas collection in any closed cavity, it can expand by almost 30% and cause pneumothorax, pneumomediastinum, and even air embolism. The risk of DVT-PTE is well known. The spread of infectious disease in such closed quarters. The chance of a respiratory muscle fatigue in COPD patients, because such a hypoxia will cause hyperventilation, which can lead to respiratory muscle fatigue. The chance of cardiac arrhythmias and ischemias because they are not able to cope to this physiological stress. So what are the methods of predicting an in-flight hypoxemia? The resting oxygen assessment can always be done with a pulse oximeter or an ABG. Exercise testing with 6-minute walk test, 50-meter walk test, and a cardiopulmonary exercise testing. PFT, predictive equations for the hypoxemia, and altitude simulation using a hypoxic challenge test or a hypobaric chamber. So apart from your regular history and physical examination of the COPD patient, where you inquire about any recent exacerbations, you ask about any previous history of pneumothorax, a good physical examination. Apart from that, you get a resting oxygen of SpO2 value more than 95 on room air. So that suggests that an in-flight hypoxemia is highly unlikely. If the ABG PaO2 is less than 70, or there is any chance of a chronic CO2 retention in the ABG, they should undergo further testing. As such, exercise testing has a very poor ability to predict an in-flight hypoxemia. But for all practical reasons, anyone who can complete a 50-meter walk or even climb 10 to 12 stairs without any distress is considered to have a good cardiopulmonary reserve for flying. PFT is not indicated for any pre-flight workup, but apart from your regular workup for the COPD as such, to assess their severity and for assessing the chance of a respiratory failure, apart from that, there is no need for a PFT. Even the predictive equations, though they are simple to use, they have very poor predictive value when it comes in the practical setting. And that is where the high altitude simulation test comes into play. Here, the patient breathes a mixture of gas with an inspired oxygen fraction of 15.1% through a tight fitting mask or a mouthpiece for a period of 20 minutes. During this, continuous ECG and pulse oxy readings are obtained with pre and post ABG. If the PaO2 remains more than 55 meters of mercury during the test, the patient is considered a low risk for hypoxemia during the travel. But if the PaO2 falls below 50, then an in-flight oxygen of 2 liters per minute is recommended. And this correlates well with the hypobaric chamber, which is what is considered as the gold standard for predicting hypoxemia at altitude. But unfortunately, the hypobaric chamber, though it simulates the environment of the aircraft cabin for an altitude of 2,438 meters, it is only used for research purposes. So supplementary in-flight oxygen is usually prescribed at a rate of 2 liters per minute. But somebody who is already on long-term oxygen therapy are advised to double their flow rate. So someone who may need more than 4 liters per minute has to reconsider their travel because most airlines may not be able to deliver oxygen at such a double rate. This oxygen is usually given through a nasal cannula. Any in-flight oxygen need not be switched on till the plane is already at the cruising altitude and can again be switched off at the start of descent. For those patients who are already on long-term oxygen therapy, they should consider taking it along with them throughout their stay. They should also increase their flow of oxygen to add 2 liters per minute. I will come to that, why that is so. Any titration using the hypoxia challenge test is suggested. All arrangements for oxygen at the airport, at their stopovers, for their transport has to be arranged beforehand. And any prior arrangements with the destination country is essential to ensure the availability of all supplies. What we are seeing here in the picture is a tiny portable oxygen concentrator. It is available from 2 liters to 5 liters, 9 liters, and even 10 liters these days. The patients must provide a 48-hour notice period of the travel plan prior to the airport authorities, along with their physician recommendations about how and when this has to be used during the flight. There was a study where different sources of the supplemental oxygen, that is compressed gas with continuous flow and oxygen conserving device, was all checked for their PaO2, and it was found that it was the same PaO2 which was being supplied. But when a portable oxygen concentrator was given, a significantly lower PaO2 value was found. So in order to achieve an acceptable PaO2 value, it is advised to increase the flow in portable concentrators. It is always best to carry a fully charged machine with additional batteries which are charged, because a power outlet may not always be assured in your flight. There are conditions associated with COPD which need some attention. For example, I'm beginning with pneumothorax. Any spontaneous pneumothorax or pneumomediastinum has to be excluded before an air travel, for which it is preferred that a pre-flight chest radiograph is done for any person with Bullous disease or a previous history of pneumothorax. This pneumothorax is an absolute contraindication to air travel. Any traumatic pneumothorax has to wait for almost 2 weeks after a radiographic resolution. Secondary spontaneous pneumothorax, the risk of recurrence is high, so they also need to consider alternate forms for at least 1 year after the initial event. DVT and PTE, economy class syndrome. This was the term used by Symington and Stack in 1977, but that doesn't mean the business class is safe. But coming to studies, unlikely that hypoxia or hypobaric changes are themselves any etiological factor for embolism. There is no reference living at high altitude or patients with hypoxic lung disease or commercial airline pilots. But a study reported that in such a hypobaric environment of the aircraft, markers of activated coagulation did increase by 2-fold to 8-fold. So any air travel of more than 4 hours duration, if undertaken in the preceding 4 weeks, is considered a risk factor for pulmonary embolism. A review from 1966 to 2005 with 25 studies concluded that all travelers, regardless of their risk, should avoid dehydration, should frequently exercise their leg muscles, and those who have a flight less than 6 hours with no risk factors do not need their DVT prophylaxis, whereas if they have a risk factor and if they are flying for more than 6 hours, they should consider a graduated compression stocking and or a low molecular weight heparin. In cases of pulmonary hypertension, which is itself a high risk of complication during the travel, there is a variability as to the pulmonary vasoconstriction which is induced by the hypoxia. But even a light worsening of the hypoxemia during the flight can induce a significant increase in pressure, leading to a serious right cardiac failure. So the 2011 BTS recommendation advises that patients in their WHO functional class 3 or 4 should have a supplemental oxygen during the travel. Now, if a hypoxic challenge test is not available and there is no actual concern regarding hypercapnia in these patients, then those who are already on LTOT are advised they only need to increase their flow rate by 2 liters per minute more than their baseline flow rate. For those who are having type 2 respiratory failure, there is a chance that during the hypoxic challenge test, when oxygen is given, there is a risk of developing hypercapnia and respiratory acidosis. So these patients should undergo the HCT with their blood gas sampling. In these cases, the minimum amount of oxygen in more than 6.6 kilopascals, along with monitoring their PaCO2 and their pH. In cases of OSA with COPD, daytime flights are advised wherever possible. They are advised to carry their CPAP device as a hand luggage and a hospital letter to advise that the patient uses CPAP. Careful planning, preparation is required. Use of their own device is what is advised. Any alcohol and sedatives should be avoided 12 hours prior and during the travel. And they need to use their device on board if they are traveling overnight and avoid sleeping if it's a daytime flight. So coming to the final travel advisory for the COPD. Any travel should be postponed for almost 6 weeks if there was a recent exacerbation. During the flight, the patient should keep all medications within reach on board and try to take direct flights as much as possible. They should ensure adequate hydration, do intermittent leg exercises, and usually select a seat closer to the toilets, preferably on the aisle. Any patient who is at the risk for desaturation during sleep should be warned to avoid alcohol use and other sedatives during long flights. Preferably, carry your physician advice along with your oxygen concentrator and your CPAP machine if it is recommended. Thank you. Now, moving on to the next talk by Dr. Anand.
Thank you, ma'am, for an excellent presentation. And now we will have a bird's eye view of altitude exposure and COPD, in which what clinicians must know about the hypoxic stress and the exacerbation risks linked to COPD. So, objectives of this brief talk will be to understand how altitude affects oxygen availability, explore the physiological responses in COPD patients, which are a special group of patients, out of which the heterogeneous population of COPD, few of the people are not hypoxemic, few of the people are extremely hypoxemic. So we'll look into that factors also, and then assess exacerbation risks at the altitude. And last is review the clinical guidelines and management strategies. Now, more into management strategies and clinical guidelines will be done in the panel discussion, which is to follow. But we'll just take a bird's eye view. So, as we all are aware, that COPD is a disorder which is characterized by chronic airflow limitation, and there is significant VQ mismatch and impaired gas exchange. And as we all know that by the equation of PaO2 and FiO2, that at sea level, we have the best oxygenation possibilities given by the atmosphere. Once the altitude increases, the rarity of oxygen is there, and hence the available FiO2 for a person decreases. And then lastly, increased susceptibility to environmental stressors, including pollution and cold air. So, dealing with altitude and hypoxia, as we know that even for normal individuals or otherwise healthy individuals, going for an altitude with a rapid ascent, there will be a drop in the barometric pressure with altitude. So, FiO2 remains 21%, but PiO2 will fall. And approximately at 2500 meters, almost 15% less oxygen is available than sea level. Now, here, the most important part is this difference will not be material for many healthy individuals who lie on the oxygen dissociation curve, the stable part or the plateau part of it. But it matters for people who are lying on the steep part of the oxygen dissociation curve. So, this response of hypoxia is going to be present in all the individuals, whether they are normal or whether they are COPD individuals. But in COPD individuals, why it is important? This slide is important is because once hypoxemia is detected by chemoreceptors, it will have a cascade of effects. One is vascular response. For VQ mismatch, the pulmonary vasoconstriction will occur and cerebral vasodilatation will occur. Apart from that, there is hyperventilation initially to maintain the oxygenation. Consequences initially, these are the initial responses, that is increase PaO2 and alveolar O2 and arterial O2, and decrease arterial CO2 and CO2 in the air, which we are expiring. But very soon, this is going to be exhaustive for the patient or patients like COPD. Then cardiac response with sympathetic stimulation will occur, and hence patient will have more of tachycardia. And the initial result is increased cardiac output, provided the patient is having a good cardiac condition or a good cardiac reserve. So, what happens in COPD? So, once there's a decreased PaO2, this is again exacerbated by VQ mismatch, because there is a more of VQ mismatch once you go to the higher altitudes. That is, ventilation again becomes a difficult task, a more challenging task. Then, due to vasoconstriction and several factors which have been still not elucidated, pulmonary artery pressure goes for a steep rise with the increase in altitude beyond 3000 meters. Then there is obviously, once the pulmonary artery pressure increases, RV goes into strain. And apart from that, there is one more problem, which is the risk of having Chinese-Stokes breathing in individuals who have pre-existing OSA. Sometimes it unmasks the Chinese-Stokes breathing in patients who are for the first time go to the mountains, who are going to the mountains, and they are not aware that they are having a sleep apnea problem. So CSA, unmasking of CSA and presence of Chinese-Stroke breathing along with heart failure patients is a common occurrence which occurs even at the altitudes of around 3000 meter, 2500 to 3000 meter. Now, what we term in altitude related adverse health events, or ARAHEs, are basically, these are not limited to the pool of COPD patients. But now we will keep our ambit of the talk limited to COPD. So basically, patients with COPD have comorbidities as well. So once patient is having severe hypoxemia, patient is having severe cardiovascular disease, patient is suffering from acute mountain sickness or AMS. The notable fact is AMS is also present in normal individuals who are prone to that. But in COPD patients, it becomes even more pronounced. So once you have subjective discomfort, patient desires to descend to lower altitude. So because they will immediately find relief if the pathology is such. But in many cases, even a descent will not help and urgent medical help is required. So, as we have figured out that COPD patients, and especially those COPD patients with limited cardiopulmonary reserve, with existing comorbidities, with COPD OSA overlap features, these are more prone or hypoxemic variety of COPD or severe COPD. They are linked to increased dyspnea, increased sleep disturbances, and increased rate of exacerbations. Here, rate of exacerbation, several studies have concluded differently. Few of the studies, large studies, have concluded that amount of exacerbations compared to normal population is not that high, but maximum studies have concluded that exacerbations increase once you ascend to a higher altitude. That is, they say that sea level is a better place for COPD people to reside. However, some different data is coming from a trial, which is Pyromics trial, which has been concluded in 2024, wherein they have said that exercising capacity goes in for a toss, but usually mortality and exacerbations do not show an increase. But we'll not go to that because apart from that, most of the studies have concluded that it increases the acute exacerbations. So there is no arbitrary cutoff to which a COPD patient should be asked not to go. So various guidelines have given different cutoffs due to different reasons, and sometimes they are backed by strong, robust data. Sometimes they are not. But overall, as a physician, we must not subject our patients to the risk of higher altitude because higher altitude comes with these many problems. So several studies have conducted and have been conducted, and they show different type of altitudes. Apart from that, the nocturnal desaturation, which we discussed in cases, in normal cases, in cases in which OSA is unmasked, cases in which there is a mixed apnea. So, who is more at risk? Now, according to ERS, that time when they had this spirometric classification of COPD, they took gold stage 3 and 4. Basically, we are taking lower FEV1 patients. And then we have resting PaO2 less than 60 mmHg at sea level, which can be again seen while we are conducting an ABG. So, and then patients of the E subtype, that is A, B, and E, the newer classification, that is history of frequent exacerbations. Then comorbid pulmonary hypertension, because we have already discussed that pulmonary hypertension independently also worsens. And there is a type of pulmonary hypertension in the classification also, which is linked to the higher altitude. And then obstructive sleep apnea overlap, which we have already discussed. So, as a physician, what is our responsibility? Our responsibility is to do as extensive assessment as possible for the patient, because at very high altitude, the availability of medical facilities and all will be very challenging for the patient. So we must keep our patients safe, because most of the time what we are talking here is for patients who are going for ascent, which is limited to fewer days of stay, and we are not talking of acclimatization. So we must assess the baseline oxygenation using ABG, and pulse oximetry also is a useful tool initially. Then we must do a 6-minute walk test and look for desaturation. If desaturation is below 85%, then we must ask the patient to avoid this, because they fall on the very steep part of the curve and they are very likely to worsen on the altitude. Then altitude stimulation test, if our center has availability of altitude stimulation test, we should ask, though it is a provocative test, and there will be a varied opinion about taking HAST in all the patients, and the panel will deliberate on that. But in general, it is not a very routinely applied test for people who are coming to routine OPD clinics. Then most important is you have to plan the activities which the patient is going to take, altitude and the duration. So how exactly we are going to manage it? Again, the supplemental oxygen for altitude higher than 2000 meter, because already air travel has been discussed in detail. So altitude of greater than 2000 meter ascent, and in ascent in how many days is to be done, that has to be taken care of, because once 600 to 800 meters, you should not ascend in more than a day. You should not ascend more than 600 to 800 meters. This is what has been recommended for severe cases. And obviously for prevention, the consideration of acetazolamide is being used. Acetazolamide is a respiratory stimulant which is going to work as a carbonic anhydrase inhibitor, we all know. And then the patient's maintenance therapy, his inhalers must be carried by the patient. That is one thing we must tell our patient, that he should have his kitty of medicines with them, along with sources of supplemental oxygen, because the higher they go, they may not have access to best of the facilities. And last but not the least, we should be the best guide to the patient, that we must tell the patient that they should be avoiding altitude in case of unstable patients. So very quickly, we'll go to the practical travel tips which has to be given to the patient. Is pre-travel screening of the patient, and who should go undergo screening is mostly those patients who are having any breathing difficulty or any respiratory disorder. Then portable oxygen concentration, and their availability and how exactly they are to be used has to be explained. Then they have to be taught that they should do some pre-warm up in the camp or wherever they are going, or wherever they can arrange it as close to the sea level, and then mark the ascent. Hydration and good sleep hygiene, and most importantly, their backup medications and emergency action plans. So this is again, it's a repetition of what I have said, that you assess each and everything, what the patient is on, how much he is using oxygen, if he is already on oxygen, if he's going to take a sojourn above 2000 meters, then what exactly to advise, how much he has to keep it, apart from bronchodilators and his regular medications. Then is his physical examination and evaluations using ABG 6-minute walk test. Apart from that, if you have facility, you can do a CPET and echocardiography in patients who have cardiac comorbidities. Then you must discuss the patient's travel plans in detail, that is maximum altitude to be rate, how much ascent rate is going to be there, how many days they are going, and how many days they can afford a stay. Because once you ascend to a certain height, you have to have some stay. If you are having an overnight stay, if you are having a 2-night stay, it will be better for you to slightly acclimatize. Then is use of citazolamide, which you can be using for the patients in which deemed fit. Then most important is, and most important line is, too risky should be discouraged. You must tell your patient that this is not worth the risk. If it is not worth the risk, it should not be done. But apart from that, if patient is a milder airway disease patient, then we can obviously go with all the precautions. And if the travel is going to be urgent only, then he or she has to understand all the risks, understand all the backup plans, and then only move ahead. Okay, so this is the same repetition of the same thing, that logistics have to be understood, that what all you are going to get at those altitudes. Apart from that, medication should be carried by the patient, because at that altitude, what medications will be available is a very difficult task. So oxygen, uh, useful medication like dexamethasone, acetazolamide, because we all know that apart from these complications, for normal patients also, the altitude related adverse health events like HMS, Haze, and HAE can occur. So that is one thing which we must keep in mind, that we should be preparing our patient as a normal patient also for ascent to these heights. And most importantly, in emergency, they should have the track of all the relevant services. Apart from that, yes, so this is what we already know, and we have been using acetazolamide every now and then in our practice, and helping patients out if they are asking this drug to be used in as a normal essence, which they are taking, not only COPD patients but normal patients as well. So, post exacerbation patients, or O2 dependent COPD, or OSA COPD overlap patients, you have to counsel them and tell them the exhaustive list of things they are going to need at different altitudes, and they must follow the ascent protocol, which is ascent of not more than 600 to 800 meters in a day, because we have to tell them this is going to be life threatening. Then high altitude dwellers moving to lower altitude may see symptom improvement, which has a regular strategy which happens whenever you ascend. If you are sick, you will go for a descent. Descent is usually helping you. And not only that, there have been multiple studies that which have shown that if COPD patients with pulmonary hypertension have descended to lower altitudes, there have been symptomatic improvement in dyspnea and functional status. So, summating very quickly, altitude exposure creates hypoxic stress in COPD. So, the special group of patients who are hypoxic are definitely bound to get problems there. Apart from that, there is increased risk of exacerbations, especially in the E group, that is the advanced stage groups. Apart from that, pre-travel risk assessment done by a physician is the key, and preventive strategies can help mitigate the risk. If they are not worth the risk, we must tell the patient. Thank you.
Those were two excellent overviews about travel and high altitude in COPD patients. It was clear, evidence-based, and incredibly relevant. I learned a lot from those two talks. A great way we have started unpacking the journey of our COPD patients beyond the clinic. I think that was, we have begun our journey of high altitude in COPD patients with a fantastic launch. Thank you, Dr. Deepthi and Dr. Anand, for that, for setting the stage with such clarity and guidelines. So as far as this COPD patients traveling altitude is concerned, I think there are guidelines are not very clear, crisp as to define what we should do at what point of time. They are a little bit vague in their own guidelines, and there is only one clinical statement from British Thoracic Society. I think that dates back in 2022. And there are various societies like ATS and other societies which give a different scenario and different cutoff for each travel and altitude. So it is not that simple to say that there is one size fits all. For example, if you see a patient in your clinic who has more than 95% saturation, a COPD stable patient, he's good to go, he's fantastic, he's not going to have any problem in travel. This is not how it goes. We really need to get into the dyspnea scale, evaluate him, what will happen to him. First, important, foremost message from these two talks is assess the patient at sea level properly. What is his take on the oxygen? What is the requirement in sea level? And then only we can decide on how we are going to give him fitness or what he has to do during traveling or mountain climbing or whatever it is. So let's start with the basics first. Let's start. We have an eminent panel, so I'm eager to listen to what they follow during their practice and how they answer their patients. So let's start at the foundation. So Dr. Sudarshan, can you elaborate on which COPD patients should undergo pre-travel hypoxia? It's not like all COPD patient needs assessment. So how do you choose your patient and which COPD patients you subject them to pre-travel hypoxia?
Thank you, madam, for the question. At the outset, I like to give the CCI family to giving me the opportunity to part of this platform, because what I think this platform is like a knowledge gaining platform rather than knowledge sharing platform. Coming to your question, ma'am, which COPD patient should undergo pre-travel hypoxia assessment? You see, basically, two of our previous speaker, Dr. Deepthi, as well as Dr. Anand, elaborate thoroughly, just a little bit repetition, that patient with COPD with resting SpO2, if less than 95, number one criteria. Number two, if MMSE score, dyspnea score 3 or more. Third is if desaturation after testing with a 6-minute walk test, if saturation come down below 84%. And those group of patients where we are concerned about the hypercapnia. Lastly, not but the least important part is those group of patients, those are on long-term oxygen therapy and prone for type 2 respiratory failure. These also needs thorough evaluation, particularly pre-travel hypoxia assessment. However, there is some group of high-risk group of COPD patient, say for like severe COPD, like FEV1 less than 15%, 50%, and those patients having severe and frequent exacerbation, and patient COPD with pulmonary hypertension, and some comorbidity condition associated with COPD, like cardiovascular and cardiological disease. These are groups needs more vigilant and more pre-flight respiratory screening before allowing them. May I repeat? Of course, this is not a exact language that fit to fly. Rather than it is a pre-travel respiratory screening or pre-travel hypoxia hypoxic assessment rather than fit to fly. Over to you, ma'am.
Thank you, sir. That was very clear and crisp. So as I told, it's not very easy to decide on a single patient because each patient will have many other comorbids, and you should also take into account a previous travel history, which is very, very useful. Previously, they have traveled in flight, then that gives you a clue as to better, clear clarity as to those patients who need further evaluation. And we also need a detailed history and a symptomatic, as sir suggested, dyspnea score, everything, and then only we can decide on whether these patients are really fit for traveling or not. So moving on, altitude brings a thin layer of complexity. We know that altitude has its own problems. There are so many, as in the lecture which we saw, they really consequences of what happens during altitude and at the cabin pressure during flight. So there are a lot of altitude issues which come into play. Dr. Pramod, how does high altitude pose a risk to these COPD patients? Can you elaborate on that?
Yes, madam. At the outset, I would like to thank the CCI family for giving me the opportunity being the panel among these august gathering of the physicians. It is very rightly said because at a high altitude, there is a less of oxygen is there, number one. And as we know the COPD physiology, there is a bronchitis and small airway and the emphysema, they already been compromised. A stable COPD patient can travel very at a higher level than 65,000 to 10,000 feet. But a patient with the moderate to severe COPD, they cannot be fit to fly more than 6,500 feet. And so, because at the higher level, when they approaches, there is a thin layer of oxygen is there, and the oxygen concentration is very low down. Patients are already being compromised for that they are not being able to take the breath inside, and they are already dyspneic patients. Since they have to because of hypoxia already and less of oxygen, there's a more pronounced hypoxia, and for the hypoxic compensation, they are having the more tachypneic, and they are going to exhale more and more carbon dioxide, and there's a less of oxygen. Maybe emphysema is also there. So first thing is about oxygen. Second is a strenuous activities causing the muscle mass to get exhausted. And the third is many patients are being get exacerbation of a COPD when they are not being properly screened over. And then there is some sorts of cardiac, because of there's a mechanical problems in the lungs, and there is maybe lungs and cardiac issues are there, and because of the lack of oxygen, there may be the some of the cardiac events like arrhythmia, some cardiac failure, and the patient may first been having the symptoms like acute mountain sickness sometimes, because because of lack of oxygen, they may have a feeling like dizziness and a confusion state. And so if this high altitude is not being properly addressed before the journey, they may go to the high altitude pulmonary edema also. So these are the few of the complications which we can screen before when they are approaching to such a high level by this proper proper chest physician consultation. Second, a gradual ascent to this. One should not have a ascent very fastly, because in that time there is maybe the trouble is more severe. And some sorts of drugs are available like acetazolamide, nifedipine, and these sorts of salmeterol drugs are there in this dexamethasone, which can be given to the some sorts of patient. Although acetazolamide is not a guarantee for that, but they can have a symptoms less among them. So I think it is a very drastic when the patient is sent very fastly to the area, and they must be screened properly to the physician when they are going to approach such a the high altitude.
Thank you very much. Sir has made two important points in this explanation. One is, please assess the comorbidities of the patient. Don't concentrate only the COPD part of the patient. Really, these patients are complex. They have multiple comorbids. Please also assess the comorbidities, which can also be a precipitating factor for this desaturation in that altitude and mountain sickness. The other point is the rate at which these people ascend in mountain climbing, if they are very quick, the rate at which they get acclimatized to this problem, and how do you advise them? If they cannot adjust so fast, you can ask them to take a break and all those things. So you need to address that part also and address the comorbidities. Thank you, sir. Thank you for that wonderful explanation. So we'll move on to our, everyday tool. What we have in our OP, what we see every day, the saturation monitor. Dr. Deepthi, is resting SpO2 enough to decide on supplemental oxygen in COPD patients? So, sir, I think in your talk, you also mentioned there is other point, which from all this you should have understood, that if your saturation, if your patient at sea level is requiring more than 4 liters of oxygen, then you cannot subject that patient to travel or mountain climbing. It ends there. They are not fit for anything. But if they are having requirement of less than 4 liters, then we need to assess them by various tools. The first one which we start with is the pulse oximeter. So let's ask Dr. Deepthi, is SpO2 enough to decide on supplemental oxygen?
Thank you for the question, ma'am. I think as the talk itself had clarified this, if you are trying to assess a patient of COPD for fitness to fly, and if the saturation is more than 95 on room air, then they are considered to be fit to fly. Provided, of course, as we've already discussed, this is not a cutthroat value. We have to assess the comorbidities. We need to look into the pneumothorax. We need to look into pulmonary hypertension. There are so many other factors that come into play. But if we are talking only about whether to give supplemental oxygen or not, then in that point, yes, respiratory resting saturation alone is sufficient if the saturation falls above 95. But if it is below 92, then the patient has to compulsorily undergo ABG and other exercise tests, and even if a hypoxic challenge test is available, then even that, preferably a hypoxic challenge test for that matter. And if it is in between, that is between 92 and 95, then again, it is a very crucial decision whether to give supplemental oxygen or not. But I think it is always better to err on the other side. That is better to advise for the oxygen rather than not subject them to any test at all. So convincing these patients for further test is, of course, a different matter, because once the saturation is above 95, they are happy and ready to go. But once they come in the borderline, then we have to convince them for ABGs and all these interventions, which are going to be painful and time consuming. It is a little difficult, but I think it is necessary rather than facing the consequence of having a hypoxic situation in flight. So if it is up to 2 liters, up to 4 liters, I think it is better to err on that side and give the oxygen rather than not do any test at all.
Thank you. I think you have brilliantly simplified the algorithm on the BTS clinical statement. Thank you for that. So I always teach my postgraduate students, saturation monitor, your pulse oximeter is a very good friend when it is abnormal, but it's a very bad friend when it is normal. So I think that holds good in all our practice, because we will be missing only when the patient exerts, we will know that their saturation is dropping and things like that. I think we should always keep that in mind throughout our practice, that SpO2 can underestimate so many things. And rightfully said, we need to follow the algorithm, what the clinical statement suggests. That's a fantastic algorithm. I suggest the postgraduates to go and read up that. So it is a clear, as Dr. Deepthi suggested, what to do if it is above 95, what to do with it 92 to 95. It's very, very clear document. So next, now that we know that SpO2 is normal, we have decided on what to do with based on pulse oximeter. Suppose the SpO2 is normal, but the patient has some breathlessness or something like that, then I think we should dive a little bit deeper into that. So we will ask Dr. Anand Vardhan, how do we risk stratify patients for altitude exposure? Meaning in which group of patients you will move beyond using only the pulse oximeter and asking for additional tests. In which group of patients in your practice do you do that, sir?
Thank you, ma'am. Thank you, ma'am, for that question. Um, as Dr. Deepthi has already mentioned that we have broadly classified this into three classes, that is 95% above 95%, below 92%, and 92 to 95%, which is that ambiguous group wherein we need to take the call accordingly. So I will broadly classify them into two groups, that is above 95% with existing comorbidities and from 92 to 95 with comorbidities. So comorbidities like existing pulmonary hypertension, coexisting abnormalities like heart failure with reduced ejection fraction, comorbidities like existing obstructive sleep apnea, or wherein patient is having dyspnea which is not in proportion with the clinical condition of the patient. All these groups need to be, or COPD patients who are, the COPD patients who are moderate to severe. Few of the guidelines take it as FEV1 of less than 50% of the usual, and few of the guidelines take it at less than 60% of the usual. So to take it in the broader spectrum of things, it can be taken as FEV1 less than 60%, which will cover both the moderate to severe COPD patients who are maintaining a normoxemic oxygen. Then, apart from that, we also need to include those patients who have been subjected to 6-minute walk distance and they have desaturated more than 88%. I mean, who has fallen below 88% of saturation. So for this, actually the cutoff which has been decided by BTS is less than 84%, but few of the guidelines have also kept it as 88%. So we can choose according to our wisdom and according to the patient profile.
Yeah, thank you. That was very clinically useful. I would like to add one point there. Some ATS, American Thoracic Society, asks you to do an ABG and look at the PO2 rather than saturation and other things. So remember that point.
Yes.
BTS is not in favor of, BTS gives a algorithm based on your saturation, but ATS clearly says do an ABG and then assess the PO2. That's one point. Yeah, so let's build on that. Now let's ask Dr. Sudarshan. So you have decided that SpO2 is not, SpO2 is okay, but they have decided that this particular patient needs additional testing. Now, what additional test would you suggest for this high group patients whose resting SpO2 is normal?
Right, ma'am. As Dr. Anand already explained, the risk stratification, particularly those group of patients required is more intensive pre-treatment evaluation or pre-flight evaluation. Particularly those group of patients where SpO2 is normal more than 95%. Next test is 6-minute walk test. So based on a 6-minute walk test, we can identify some of comorbidity, particularly if 6-minute walk test saturation is less than 84%. Again, this group of patients required oxygen. Next thing is, as you explained, because this 84% of SpO2 less than 85% in 6-minute walk test is based on the BTS guideline. And as you explained about the ATS guideline, that if the person having say midline, then ABG may require. What are the meaning of the scientific basis about the ABG? Those group of patients who are risk for hypercapnia after giving the oxygen. That means during our oxygen challenge test, if patient required oxygen, whether that oxygen having prone for hypercapnia or not, that needs clarification based on ABG only. That's why ABG is required. Even also in BTS guideline, they have mentioned that if a person having saturation less than 90%, in that case, we required to confirm ABG as our fast track Dr. Deepthi already explained. The basic requirement of minimum PO2 value in flight is about 50 millimeter of mercury. That is important. That's why we need to identify those group of patients where SpO2 is less than 80%. It's very often unstable to find out the exact PO2 value. That's why ABG needed. That means in summary, if SpO2 is normal, we require 6-minute walk test and we require at time ABG also. Over to you, ma'am.
Thank you. Thank you, sir, for highlighting the diagnostics. I think this is just the basics of any pulmonary disease. Start with the history. Ask for, it doesn't depend on one particular parameter. So I think from the history, you need to have a dyspnea scale. You need to have the saturation pulse oximeter. And then if in doubt, do an ABG, go for the 6-minute walk test. All tests need not be done in a particular patient, but accordingly, you have to choose what diagnostic you have to choose on individual patient, and you have to go through the entire steps before giving them a clean sheet. So let's move on now. We would ask Dr. Pramod, sir, what are the recommendations for COPD patients traveling to high altitudes? Dr. Pramod?
Yes, madam. The recommendation for the patient with the COPD at high altitude, they must, if they're traveling to the height more than 6,500 feet, and if they're having the severe COPD, they must be discouraged to go. If their baseline of SpO2 is less than 85, and if there are patients, they're being properly evaluated whether they're fit to fit or not to get that their source of high altitude. And secondly, the patient must be aware of the what acute mountain sickness can be there, and many of the times if you are not going to discuss this issue, then they will be in trouble. So oxygen requirement should be assessed initially before going, and their ample medication should be supplied in an inhalation form with the steroids, and all medicines should be with them. If you are not being properly given them, they can be in a deep trouble if they are not being. So there should be advice for a gradual ascent. Number one, to just see for any of the comorbid condition apart from this cardiac and some other metabolic syndrome can be accompanied with them. So if we are assessing them properly, and the ascent should be very gradual, number one, and there should be very stable patient, because any patient having the exacerbation in last 2 weeks before, they should be not be given the fit to reach their this of altitude. So these are the few of the points which must be keep in the mind when we are giving any patient a fit or not to get a recommendation for high altitude COPD patient.
Thank you, sir, for that helpful practical tips. So now you have decided to give either supplemental oxygen, or you've decided to give a prescription for a patient who's going for a COPD patient who's going to travel. So prescription, it's just not an art, it's a strategy, it's a plan. You're going to propose a plan. So let's ask Dr. Deepthi, how do you titrate oxygen? How do you give a prescription before writing a prescription for a patient on how much oxygen he needs, what he needs? How do you titrate the oxygen? Should we simulate? Should we do a HAST, that is hypoxic altitude simulation test? Should we exert the patient and do a 6-minute walk test? Or should we extrapolate, or should we just go with the clinical judgment? Dr. Deepthi?
Thank you for the question, ma'am. I think for all these options, the best answer would be that provided you have these, machinery and all your equipment at hand, if a hypoxic challenge test or the high altitude simulation test is available with you, I think there is no better, test to run to when you're trying to titrate for oxygen levels. So if a HAST is available, then definitely you get the test done. And if the hypoxemia is severe, then immediately give the supplemental oxygen and titrate with a post ABG and determine that the PaO2 is above 50. And if it is at the whatever value of oxygen is giving a PaO2 of more than 50, then that is the titrated oxygen to be advised. But suppose there is a setting where HACT is not available, then we go for the exercise testing. So in such situations, a 6-minute walk test is performed. And if there is a desaturation, a significant desaturation, then again, in those cases, a supplemental oxygen is given and the 6-minute walk test is repeated. And if again the PO2 is above 50, I think we have to, that is the titrated oxygen that has to be recommended. But there are settings in India where all these conditions, all these equipments are not possible. A 6-minute walk test may not be possible. A pulse oximeter may not be available. So in these cases, a complete clinical evaluation is what will be sufficient and helpful. But when I say clinical, it has to be a very detailed setting where the doctor is able to assess the level of dyspnea, is able to assess whether this patient is hypoxic or not. And if the setting is not permitting, then better to refer to a place where such a detailed evaluation is possible rather than blindly giving a fit to fly certificate. So the problem with prescribing supplemental oxygen is that we should be well aware that anything more than 4 liters will not be accepted by the airport authorities. So the patient should be having a portable oxygen concentrator, which is not feasible and it is quite expensive for most of the patients in our Indian settings. So all these recommendations have to be titrated to the individual customized patient. If the question is whether 4 liters is sufficient, then yes, you can recommend that the airport authorities themselves will provide. Of course, the payment and has to be by the patient. But if it is anything more, then that is specifically I'm talking about the LTOT patients, then they need to be having an access to a portable oxygen concentrator.
Thank you. Thank you for that clear explanation. I think the most important message here is hypoxic altitude simulations test. I think in India, nowhere there is a center where you can do it very well. I'm not aware of anything like that. And it's not a simple test. You need a backup plan. You need a ICU team ready and things like that. I think it's like, something like a research in India. I don't know anybody has that. So most importantly, the one thing which I would like to add here is no patient walks out of the textbook. Nobody has only COPD and then come to you, you assess only COPD. It doesn't work like that. Most COPD patients have uncontrolled diabetes, they have cardiac comorbids, they have some CVA, they have so many other issues. And to add fuel to the fire, only these group of patients want to travel from here, the elderly group, who they want to go from here to the US and things like that. So we are having a real mess here, and we don't have a go-to test to just subject them to be very clear and say that this is what you are passed this test, you are fit to travel. We don't have anything like that. I think it comes from clinical experience, previous experiences, the patient's previous travel, and in high altitude, you should not advise them to travel at a stretch. They need to take a lot of breaks, even if they have a supplemental oxygen. And so clearly there is no one size fits all. Individualize your patient, go through all the tests, and then decide on what is best for your patient. So moving on. So now we have talked about a patient who's requiring oxygen supplementation. Now, there are patients who are already on oxygen who want to travel to see somebody in the other continent or in the other countries. So we'll ask Dr. Anand, Vardhan, in COPD patients who are already on long-term oxygen therapy, how much should the oxygen flow be increased and how do you decide on that? Dr. Anand?
The first, thank you for the question, ma'am. So first part of the question, again, there are two ways of doing it. One is doing a high altitude stimulation test, which again is not available, as you have rightly pointed out, ma'am, that we aren't aware of many centers in India who have this facility, or even one center, I can't recall, who has HAST facility available. So second is the Indian method, which is like empirical method. So in empirical method, what we do is whatever is the requirement of the patient, you simply add 1 or 2 liters of additional oxygen flow to it. Though it is not a very accurate or a very scientific method, but this will help the patient cope up with the hypoxemic stress at that altitude for say 2 or 3 hours of air travel. But if we are talking about longer air travels, then that is even more challenging, because then for that matter, post COVID, we have seen availability of higher flow oxygen concentrators available, and the paradigm of oxygen supplementation devices is increasing day by day. It has now progressed a lot. So we have now pulsed oxygen concentrators with higher flow rates available, but then again, availability subject to availability in all the airports and all the places. For even for international airports, right now we are not having that kind of a good oxygen backup, or even the airport authorities are not that well trained. So it is always good to have a good hospital backup which decides everything. And if the patient is requiring 1 to 2 liters, they can add 1 to 2 liters more. Say, if we are talking about a patient who is requiring, say, 2 liters at baseline, he may take it at 4 liters per minute.
Thank you. You have made a very, very important point, which I have forgotten. So the one important thing in this travel is you should have a detailed travel history, as you said in your talk, right? So the most important thing here is what is the destination they are going. If the destination is also a hill station and things like that, you should remember that. And what is the time zone they are traveling? Starting place will have a different time zone. Their destination will have a different time zone, and how long is the journey. So as he rightly put up in that slide, you need to take a detailed history of the journey, which is very, very useful. So so that brings us to the next question. So what goes up must come down. So should we apply that to oxygen? So you have started this patient on supplemental oxygen. We'll ask Dr. Sudarshan, what do we do when the patient finishes his travel? Say he has landed. How do you decide on when to stop the oxygen therapy? Is it immediately after travel or once the patient returns to sea level? What is your take? This is a common question, but unfortunately, there are no guidelines to clearly say what we should do. We'll ask Dr. Sudarshan sir how he would answer this question to his patient.
Yes, ma'am. It's a valid question by the passenger. But thing is that, of course, there is no strict guideline. But one of a prospective study I have seen, based on the document, they have found out that those group of patients, those who are hypoxic during their flight, they are more prone for unscheduled hospital visit within the span of 1 month after the completion of the travel. That means is there in their study, the prospective study, they have pointed out that 20% of particularly hypoxic patients, those who are hypoxic during the air travel, 20% of the patients are unplanned schedule or unscheduled hospital visit after the completion of travel within the span of 1 month. That means probably that is a clue. So there is some sort of trigger factor in hypoxia that can persist even after completion of travel. Then there is a term called hangover hypoxia. Very beautiful term called hangover hypoxia. What does it mean? That means those group of patients, those are hypoxic in air travel, some sort of intellectuality, some sort of cognitive dysfunction will persist even after landing the flight in a sea level also, at least up to 4 hours. That means these group of patients, that's hangover hypoxia is probably due to the neurological delay, the neurological acclimatization, even though even patient is not hypoxic in the sea level also. That's why basing on this principle, what I think, yes, scientifically, we should stop oxygen even once patient is at sea level. But patient needs to be observed or followed up at least for 1 month, particularly those group of patients, those who are taking higher oxygen during the flight. Means to particularly to find out any unscheduled or uneventful situation during the post-travel period, at least for 1 month. So based on this study, I interpret probably oxygen may not require, but we need to vigilant about this group of patients. Over to you, ma'am.
Thank you, sir. So thank you for enlightening me that hangover is not only with alcohol, it is also with hypoxia. Okay.
Exactly. Interestingly, ma'am, that hangover, hypoxia are more seen in alcoholic also.
Thank you. Okay, we'll ask Dr. Pramod, sir. He is the most senior-most person in this panel. We'll ask a difficult question for him. So what are the pathophysiological changes in high altitude which cause the COPD patients to worsen during their journey?
Very important question, madam, in this whole seminar. Because when patient with a COPD, severe COPD, go to the higher altitude, the inspired oxygen is going lower down. So the alveolar oxygen goes down. So arterial oxygen goes down. And body is going to adjust by the lungs, by the increased minute ventilation. So patient take the respiration much more faster. So during that time, his oxygen is getting improved, but the carbon dioxide is going down, and he goes from respiratory alkalosis. Number one. Second, there are some source of a short-term adjustment and sometimes long-term adjustment. Because of the hypoxia, it stimulates the carotid receptors, and it is reflecting impulses to the brainstem, and thus causing the increase in the cardiac output. So cardiac output and this is going to increase as the blood flow into the important areas. And there is a pulmonary arterial vasoconstriction is there. So just to make the more and more oxygen from the alveolate, which is the alveolar containing more and more oxygen. And there is an increased diuresis also, because there is a loss of bicarbonates into the urine. And because of hypoxia, there's a polycythemia just supposed to, and there's angiogenesis into different parts. So there's a very vast cascades of the pathophysiological changes with the occur, and this is going to in turn into the acute mountain syndrome and acute pulmonary edema. Sometimes there is a sleep disturbances. There may be the confusion that the polycythemias, and so there's a vast cascades of the physiological changes to the body because of the gas exchange and this in going to, and there is an increase in 2-3 these phosphoglycates also. Well, because there's an oxygen hemoglobin curve is there, which is going to deliver oxygen to the lungs and this brain part. So these are very important things are going into the whole body, where vascular response, ventilatory response, and this cardiac responses are playing simultaneously and making the body to adjust that source of hypoxia. And many patients, when they are into that area, they get adjusted to that source of hypoxia. And many patients of the serious COPD, they can have a carpulmonale if they're not being diagnosed properly at this high altitude also. So over to Madam.
Thank you for the textbook perfect explanation. You made an important point here. As I told you, we need to assess the comorbids as well as see the patient as a whole. Because our pathophysiology is not restricted to the respiratory system, it has an impact on the cardiovascular system as well, as sir rightly explained. So let's move into the next part. Simulation testing, as I told you, is underused but very, very powerful. So now suppose you are able to do, this is for theoretical purpose, as I told you, our HSAT is not available. But in a special situation, if you are able to do a hypoxic challenge test or hypoxic altitude simulation test, how do you interpret this stress? We'll ask Dr. Deepthi, because she has given a very wonderful talk on this. Let's ask her how to interpret this HSAT.
Thank you, ma'am. So we begin, I think I will give my reference for the BTS statement here. We begin with a saturation, and if the resting saturation is more than 95, then the patient is considered to be fit for flying. And if the saturation is below 95, and there are other comorbidities, or the patient is dyspneic, and we are suspecting that he will have a hypoxemia on exertion, then it is recommended to have an ABG done. And if the ABG is anywhere below 50, then this hypoxic challenge test is given. And as I have already mentioned in my talk, it is nothing but giving an inspired oxygen of 15% for almost 20 minutes. So if the patient is able to tolerate such a hypoxic level for 20 minutes, and at the end of that the BaO2 is above 50, then the patient need not have any supplemental oxygen, and it is considered that they will tolerate that in-flight high altitude hypoxemia very well. But if that is not so, then only if the saturation, if the PaO2 is below 6.6 kilopascals or 50 millimeters of mercury, then we need to make sure that we give that supplemental oxygen and titrate it and find out at what level of oxygen it is falling above back to normal. Now, the other issue with this hypoxic challenge test is that not all patients will tolerate this hypoxemia for that complete 20 minutes. So even in those conditions, we need to reconsider the flying fit to fly certificates. So if they are not able to complete the test, if they are not able to, even as I was saying, not able to complete the test for that complete 20 minutes, even that is considered unfit for travel, apart from the other algorithm, as I have already mentioned.
Yeah, thank you. I think one message which you should all remember is, in a COPD patient, if your SpO2 is more than 95%, and that is not sufficient, and your MRC dyspnea score is 1 to 2, or your 6-minute walk test desaturation does not fall below 84%, that's fine. You don't need any more tests. You just send the patient fit for traveling. So this is the BTS document. I've simplified it in one this thing. And the most important thing is all other groups need further evaluation. They need an ABG. If you don't have an HSAT, go for an ABG, go for other tests where you're totally convinced. So this is one thing we should remember. Do not look at only the SpO2. Please take a history and look at the dyspnea score. This is what the BTS guideline says. Not SpO2 alone, along with your dyspnea score, is what they have given in the algorithm.
So, and may I also add here, ma'am, that we are only talking as about COPD and about the oxygen and the hypercapnia and other things. But I think we need to also highlight the importance of looking for pulmonary hypertension. So if it is a severe pulmonary hypertension, even those cases need to be evaluated in detail. And if it is, as I've already mentioned, if it's a high...
We are having a discussion after this. Very true, very true. Yes. Okay, let's move on. Now, some group of our COPD patients phenotype, we would have seen bulla, barotrauma, which are the real concerns. So if such patient comes to you, Dr. Anand, Vardhan, what would be your recommendation for air travel for these group of COPD patients with a bullous emphysematous phenotype? Dr. Anand?
Yes, ma'am. Apart from these particular phenotype, I will just try to highlight this particular phenotype of bullous emphysema, because the other recommendations for the COPD patient remain the same. I mean, the other part of what we have already discussed, that will remain the same. Apart from that, this phenotype is more prone for pneumothorax, as we know. And there are three things that we must tell the patient that when he should actually absolutely avoid travel. That is, one is a recent pneumothorax, which has happened in the past 6 weeks. Then if there is an untreated pneumothorax, which is still resolving, then we must ask the patient not to do air travel or avoid an air travel as far as possible. And then patients who are having giant bulla, which is like defined like a symptomatic giant bulla, which is having symptoms like chest pain, heaviness in the chest is there, or which is occupying the 1/3 of the hemithorax. So even a asymptomatic giant bulla can be permitted. There have been studies that are showing that giant bulla also did not have that kind of expansion, that only moderately increases the risk of pneumothorax. But then, having said that, we must insist and we must emphasize on the patient that what risk, whether it is worth the risk. What I have already mentioned, that he must decide that if he can take a train to same journey, he can take a train to same journey. Why to take that risk of that altitude? So one thing is this. Second part is they have to inform the airlines in prior that they are having a bullous emphysematous disease, which can demand an in-flight emergency of a pneumothorax. So airlines, if possible, they can have some provision for that. This is what has been written in guidelines which have come from abroad. I am not aware that whether in India at airports we have the such forms, because the forms which I have come across, the fit to fly forms, they have a very blanket statement. They don't have this specific statement. I didn't come across that whether bullous emphysema is there, then what in case of emergency, what should we have? So this is all we would recommend those patients, especially apart from the standard recommendations which we are going to give our COPD patients.
Thank you. Thank you. Very well said. Actually, there are no guidelines which addresses this particular phenotype. But I think patient with bulla, I think we can keep him grounded. We can, as you said, advise him to have an alternate travel rather than subjecting him to this pressure differences, which is definitely going to be a high risk for a pneumothorax. So, and the most important.
May I add here, ma'am?
Yeah.
There was a very interesting study where 2 cases of chronic pneumothorax were allowed to fly, and they were assessed for complications, and they were assessed for any difference in the size of the pneumothorax, and PFT values, everything was considered, and there was absolutely no change, and the patient traveled very comfortably. So it was quite amusing to think that a chronic pneumothorax did well. And but of course that is not the same with an bullous emphysema. The risk is always more with these cases, but I thought that it was an interesting study.
That I think those two patients are very lucky. So we are not God to predict which patient will have a problem, which I think it's better to explain to them that once this happens, it can cost you your life in no time. So, like by the time the patient, the flight comes back and then they reach an emergency, I don't think that delay they will withstand. And for all practical purposes, I will always say that whether it is a small bulla or a big bulla or whatever, the pressure difference doesn't matter whether it is small or big. And the more important thing is, even a small bullous patient will have one LRTI, he will have one severe cough, and then you send him for a flight, he will have all things added to that. It's only fate and it's God's God's decision. So we should be very careful when instructing these patients. It's better to say a big no to these patients. If they want to take the risk, it is their risk which they are taking to travel. So, okay, so we have covered most of the topics. Now let's take a practical travel trip from Dr. Sudarshan. So what precautions would you include in your travel oxygen prescription? Like say a patient has a oxygen, supplemental oxygen through mobile oxygen. What should you advise him regarding his backup battery, altitude adjustments, or some small oxygen prescriptions? Dr. Sudarshan?
Right. As my previous speaker already, Dr. Anand told about whenever we are planning for the flight for the patient, we need to know the duration of journey. Because based on the duration of journey, we can anticipate what is the duration of requirement of oxygen. So, as you have told, ma'am, particularly portable oxygen concentrators are usually battery driven. That means passenger need to know the duration. Say, for example, a duration travel is 4 hours. Patient should keep at least 1.5 times of that. That means patient should keep battery backup at least for 6 hours. so that there will not any problem during the flight. Second part also, there should be a backup plan. Suppose some malfunction of the battery, there should be a backup battery also, so that there will be no problem during the travel. Second part of the question is about the, suppose majority of flight used to design the pressure level is about 8,000 meters like that. But at times, for few some critical situation or some emergency situation at time, altitude may differ, particularly up to 10,000 feet sometimes. In that case, because altitude differ, the pressure drop, the oxygen requirement may be more. That's why, of course, their requirement is very minimal, because very rarely flight go above the 8,000 feet. You are particularly a cabin pressure like that. That's why these two things have to be kept in mind: backup battery and backup charge battery and separate battery, and also regarding this next part about what I as my Dr. Anand already told about that. Prior to inform the airport authority or airlines that even we have to think of about the layover plan. Suppose two flight, whether the airport where passenger has to stay, sometimes the availability of the oxygen in that one time to also take into account. That's why total duration of flight and the total journey side, destination side need to be planned accordingly. That's why that is a very important task. Over to you, ma'am.
Thank you, sir. Thank you. See, that again brings us to one clear repetition that travel history, journey history is very, very important. And also another point which we all did not stress on is how whether the patient needs oxygen at sea level itself, as soon as they enter the airport while boarding, or only during in-flight, and when they get back to normal, immediately can you remove the oxygen, or you need to give them till they, even at sea level, till they finish the journey, post-journey, and things like that. So we should keep all this in mind. So as Dr. Pramod sir clearly described the pathophysiology, let me pose another question to him. It's about the signs of oxygen. So what are the key things to understand about COPD hypoxia? Dr. Pramod sir?
Yes, madam. Thank you so much for a nice question. COPD as per se is a obstructive airway disease of the bronchus, small airway emphysema. There's a lot many mucus secretions, bronchoconstrictions, inflammation, and alveoli also fibroso. It is already compromised as per se for oxygenation. When it is going to the high altitude, their lack of oxygen are the very cold and where do you going to lower down? So at some point of time, the physiological changes may occur for the minute ventilation to increase over. But gradually, the patient is going to get the less oxygen to the brain, and he become restless, confused sometimes. And there's a compromise because of the alveoli and the bigger bolus of the emphysematous. There's a compromise of the cardiac functioning also. So there is a lungs and cardiac are involved. Apart from, because of the less oxygen, there is a acute mountain syndrome, and there may be the acute this high altitude pulmonary edema and cerebral edema can be the one of the direct complication which can occur. So looking to that into our view, we must very carefully and then the patient, because sometimes patient may have some sort of infection into the lungs when they are going to this high altitude, and so patient should be supplemented oxygen and should be bronchodilation should be proper, and all these medications should be properly given before the patient is given life. So patient may turn to ARDS sometimes. So the other few of the complication of the when patient are not being properly evaluated and he already is hypoxic and going to the area where the lack of oxygen is there. So pulmonary hypertension is mentioned earlier. It is very important to be considered because hypoxia going to constrict the pulmonary arteries drastically. And there's polycythemia has already been there because of the chronic COPD patients. And there's a systemic inflammation basically in a COPD chronic inflammation. There's whole of this going to cascades are vulnerable to get early morbidity mortality.
Thank you, sir. Thank you. Yeah, so in COPD patients, we all know hypoxia and hypercarbia, both are problems. So we need to address each component as a whole in an individual patient. So let's ask Dr. Deepthi about hypercapnia, which adds a layer of caution to these patients. So what are your considerations for prescribing oxygen in a patient who has some borderline or mild increase in PaCO2? Dr.
So,
Deepthi.
thank you, ma'am. Here again, there are two kinds of patients. There are the kind who have already been diagnosed as a type 2 respiratory failure. So they are the patients who are already on a CPAP or a BiPAP machine at home. So for such patients, just like in the OSA patients, they need to carry that machine along with them and make sure that they are using it throughout the travel, particularly when they are sleeping. And if otherwise, in the other cases where such a type 2 respiratory failure is not already diagnosed, and these are the patients for whom we need to find out during their 6-minute walk test, or if there is a hypoxic challenge test, then during that test, whether the ABG is recording any increase in CO2 when the oxygen is being given. So when we are titrating a supplemental oxygen, if there is a corresponding increase in the PaCO2, then these patients need to be, we have to be double careful about the supplemental oxygen that we are going to advise these patients, and whether these patients also need an additional CPAP machine along with their supplemental oxygen. So the concern with hypercapnia is that for patients who may not be having a baseline hypercapnia, a supplemental oxygen can precipitate hypercapnia at such a in-flight hypoxemic condition, hypobaric and hypoxemic condition. So when these patients are advised for supplemental oxygen, we can also double the rate of the oxygen. By increasing the oxygen, we can reduce the chance of a hypercapnia happening in these patients. Thank you.
Thank you. Yeah, this is a difficult task for anybody. So you will have a variety of COPD patients, having hypoxia and hypercapnia. You try to correct the hypoxia, the hypercapnia becomes worse, and then you try to correct the hypercapnia, then there is hypoxia. Such a difficult situation. I think all of us would have faced day in and day out. I think this is such a difficult question, and no guidelines addresses this problem. In a special scenario, I think you can take 1 or 2 days, because we don't have the HSAT which is available to us. I think you can give BiPAP and oxygen at your, titrate for 1 or 2 nights, and then follow it up the next day with an ABG, which makes a practical sense to say which one we are addressing. You can give a target saturation saying that do not exceed 90 to 94% in a particular patient, and then you can give non-invasive ventilation like BiPAP. So you can give both or strictly adhere to the target saturation in some patients. I think this is purely individualized, and how the patients respond to that and how they are comfortable with the BiPAP. So many things we have to look into. So now
so difficult to convince our regular type 2 respiratory to carry a CPAP to their homes. So how to convince the ones who are diagnosed later?
Very, very tough job. I think these patients also, if they have hypercarbia to a certain extent, we should advise them not to travel in the first place, take alternate travels or things like that. In a particular situation where they want to do this, then they have to go for a rigorous, testing or rigorous way of assessing these patients on a continuous basis for 3 or 4 days, maybe inside the hospital or outside the hospital, and then only we can ask them to fly. Yeah.
Yes.
May I add one thing, ma'am?
Yes, sir, please.
Okay, the concern about the hypercapnia is level up based on the BTS guideline. If PCO2 raise more than 1 kilopascal. That means roughly around 7.5 millimeter of mercury. That is the concern. If I am giving the oxygen, if we are feeling that PCO2 more than 1 kilopascal, that is a concern.
Yes. Very true, sir. The BTS statement mentions this. Thank you. Now we'll move on to the most important thing. When a COPD patient meets with pulmonary hypertension, I think everybody wants to know what we will do. Does the altitude equation change? We'll ask Dr. Anand Vardhan how he manages these patients with COPD and pulmonary hypertension who's planning on high altitude travel or air travel.
Thank you, ma'am. So, as we have already discussed, that pulmonary hypertension is going to worsen any which ways. Once you are subjecting a patient to a certain altitude, that then obviously the normal physiological response also is for the arteries are constricted. So basically to match the VQ mismatch thing. So pulmonary hypertension is going to worsen. So what we are going to recommend as a person is, most importantly, we need to risk stratify our patients first. So once if your patient is coming to us who is a known case of pulmonary hypertension, then we must subject the patient again to a battery of tests. Apart from taking good history, that 6-minute walk distance is important, and a 2D echo, in which echocardiography we'll have to, as we very fondly write it to our cardiology friends, that please do a right heart echo, so that they will insist on the right side of the heart. So they will give us the RV, any RV dysfunctions if present, or if where the pulmonary artery PSP is high, and whether the patient is under severe PH or with a mild to moderate PH. So if we have the gradations with us, and thus if the 6-minute walk distance shows sufficient desaturation along with out of proportional dyspnea during the test, then if a patient is having severe PH with COPD with sufficient significant desaturation, we must discourage the patient from taking any such adventurous travel. I mean, from taking any flight or any going to any higher altitude in a rapid accent if possible, because any which ways patient will be coming us only for advice. He will not be allowing us to veto him from doing anything. So we must be explaining the mortal risks, that if it is worth the mortal risk, take that risk. Now coming to those cases which we encounter most commonly, that during the 6-minute walk distance, if it goes, so again, what the cutoffs I am discussing, it is mostly arbitrary from several studies which say that if the cutoff, if the patients normoxemic patients drop down to 88 to 92% along with exertional dyspnea, and there is moderate pH with moderate RV dysfunction or no RV dysfunction, then you may allow the patient with oxygen and all the loads of instruction which you would like to give to the patient. And the best part of the group, which is the low risk group, as in the patient is normoxemic at sea level, having very low grade of pulmonary hypertension, and having no dyspnea as such on the 6-minute walk test, you can safely allow the patient with oxygen, because for pulmonary hypertension patients, guidelines say that we must recommend the patient that they should carry in-flight oxygen. So this is what guidelines say. So apart from that, but
for making a complex subject very simple, but then it's very, very complex and very, very difficult to answer. So I think from what he has said, the take-home point here should be, first, assess the pH, risk stratify the patient, and also group the patient, which group of pH he belongs to. He can even have a cardiac problem, which is a reason for the pH. He can have OSA, which is a reason for the pH, and adequately, optimize the treatment for the primary disease first. And then also assess whether this patient is in full-blown right heart failure or not. So this is a very, very risky group. And I would suggest, if you have a severe pH, you better not ask them to, a COPD patient with severe pH, you need to work them up through many tests, because you should look for other causes associated with COPD. So it's really a tough job, and the investigations also cost you so much before you really give them a fitness to travel. So we should keep all these in mind, and then assess the patient, and then give him supplemental oxygen. And even before flying, I think, overnight oxygen for few days before flying, all these on a case-by-case basis, we have to decide. So definitely age becomes a problem. We know that geriatrics is a tough a subject for any disease. It adds fuel to the already existing fire. So we'll ask Dr. Sudarshan, does age and altitude mix, and what effect has age on this group of patients who want to travel or to climb a mountain? Altitude and age, does it what do you correlate between these two in your practice?
Yes, ma'am. Both, as you explained in your introductory speech, that most of the COPD patients are elderly. Yes, age and altitude mixed is very important part here, because as you know, age, particularly the age of 70, more than 70, the FEV1 is as a non-linear phase of accelerator rate is decline more faster than the before 70 of age. In the elderly individual also, there is a reduction in chest wall compliance, which like to increase in more air trapping in COPD also. And this group of people, particularly elderly individuals, having respiratory muscle strength is quite decreased strength. Important part here, there is in elderly individual diminished ventilator response to both hypoxia as well as hypercapnia. That means this group of patients are more vulnerable to the ventilator failure during the high demand state, because flight or altitude is the high demand state. That's why this group of patients are more vulnerable to ventilator failure. That's why both the elderly and the altitude mixed having more, because elderly population having reserve capacity is less, more vulnerable for the stressful situation. That's why during our pre-flight assessment, we need to keep in mind that age also an important factor as regard to air travel and requirement of oxygen, and occurrence of uneventable situation is also there. You have to keep in mind during our pre-treatment or pre-flight assessment period. Over to you, ma'am.
Thank you. So aging physiology affects all systems across all, it poses a risk for everybody, but unfortunately, these are the group of patients who come to us, day in and day out, who want to fly. I think this also is again a case-by-case basis and very difficult to understand what will happen at that height. We should remember that this group of patients, ideally, if you have a hypoxic altitude simulation test, it will be better. But I think even in a given patient who is, about, as you rightly mentioned, above 70 years who want to fly, I will do a complete workup, I will do a ABG, I will not underestimate just by looking on SpO2. We'll give a detailed investigation in this group of elderly patients so that we don't, even if we give a fitness for many patients and we lose one patient because of that cuts a sorry face for us. So in this group of patients, please be over-investigate than under-investigate these patients. So now we have talked about most of the aspects. Let's now talk about planning and prevention in this group of patients. So let's ask Dr. Pramod, sir, what is your prerequisite checklist for COPD patients who are traveling to high altitude?
Very important question, madam. As a COPD patient must have a proper clearance from a chest physician, number one. They should not have any source of aggravation, infection since last 2 weeks. But he must be some stable patient when we are examining. They must have a good health, because if they are a poor health, poor nutrition, they may not going to affect going to land into some of the trouble. They must be educated about the potential hazards of the this high altitude syndrome, like when they are going to plan. And before going to give them, they must go for the proper X-ray chest, ECG, echocardiography, ABG, pulmonary function test, 6-minute walk test. And if they need, like they may be these boards criteria may be again the assess, which is a very simple tool as is clinically mentioned. And apart from, patient must be vaccinated properly, because there may be chances for some of the infection of stress. They must be taking the carbohydrate in a proper concentration with all these vitamins, vitamin D and C, all in the proper proportionate. They must have ample oxygen because the oxygen may be lacking ahead. So there should be ample oxygen, ample medication, inhalation form, steroids also, and they must all advise all these gradual ascents and this they're all comorbid condition medication should be take them. And above all, the medical insurance is very important because the patient going to land up in trouble, they are going to exhaustive bill into medical science. So there must be a proper insurance before they are going like. So I think we are advising such a big list and big things. This is enjoyable journey at this age as COPD patient who already smoked so comfortably in whole lifetime and now enjoying for the flighting in the bigger areas where we used to see many patients going to Badrinath, Kedarnath, they are not going to return back because 5-10% patient we saw in our clinical practice COPD, they gone, all the relative goes with the baldness into the hair. When they ask them, they will Dadaji wahi reh gaya. But I think they must be pre-advised. They may be have a happy journey. Thank you.
Thank you, sir. I think individual practice, all of us need to have what all points we discussed throughout. I think we need to check on each detail before giving this fitness. And that brings us to another one important point. There is a difference between travel within the country and an international travel because this the height at which they go and the cabin pressure also differs. So some in a selective case, like you can give a fitness for a patient who is even having, for within the country, like traveling between the cities, Mumbai, Delhi, Chennai. The international travel is a different ball game. We should remember that point also. So next we'll move on to as we talked, sometimes the best advice is to stay grounded. Don't give them fit to travel. We'll ask Dr. Deepthi. So when should pulmonologists discourage travel altogether in COPD patients?
Thank you, ma'am. I think that's a pretty simple question after this exhaustive discussion. Any COPD with LTOT requiring more than 4 liters of oxygen is considered unfit, so better to discourage. Any recent pneumothorax in the past 2 weeks, discourage. Any recent exacerbations, discourage. Apart from that, the few areas where there is a little, equivocal decision is type 2 respiratory failures, the OSA overlap, asthma overlap, the bullous lung diseases, then severe pulmonary hypertension. So all these have to be evaluated individually, and it is a very complex comorbidities which have to be considered before we advise whether to travel or not. But as ma'am has used the word correctly, it is best to discourage them rather than jump to give them a fit to fly. They would be happy to get that certificate, but it is best that we err and we say that we discourage them from the travel totally and opt for a better, safer way of travel than by air. So I think apart from this, a few known conditions are contagious infections and any recent surgeries. So I think all these are known points to be considered before we advise for travel.
I think you have covered all the list. I would say one saying comes to my mind: better to be safe than to be sorry. So I think that fits in with all this group of patients. So finally, we'll come to Dr. Anand. So finally, are we good? Are we guidelines ready for Everest climbing or for our travel? Are current oxygen guidelines sufficient for travel to extreme altitudes? What's your take on this, doctor?
So, ma'am, we have already seen that we all must have read more of altitude meds in the last 2-3 days than we read ever. So what I was going through is whatever literature I went through, most of the calculations were done at a height of 2,500 to 3,000 meter, which roughly translates to 8,200 to 9,000 feet. This is maximum they have gone. So if we are talking about, say, even Everest base camp, it is very, very high from what we are talking. And the FiO2, what we are expecting there will be around 7 to 8% as compared to even our hypoxic stimulation test, which we are doing at, say, 15% of FiO2. So the response of the body of a person who is already challenged, I would rather say that why one has to go to Everest Base Camp. That may well be the final destination of a COPD patient. That because even for normal people have to go through hundreds of battery of tests. So for extreme altitudes, I think that it has to be very, very systematic. It will take a lot of ascent plan has to be revised. There has to be a contingency descent plan. So if somebody is taking mountaineering after having COPD, and if the person is even mild COPD, then also they will require a lot of changes in the plan. So I think guidelines are for catering a wider audience. Mostly, this is for an individual person who might have that last wish that okay, I will go to Everest Base Camp and that may be my last destination, because extreme altitudes are not meant for patients who are going to challenge their health against those extreme conditions with these compromised lungs and everything. So I think we don't need guidelines. We may need help for those patients, or we may need specialist agencies which can help them climb to slightly higher altitudes than what they are able to climb right now. This
Yeah.
is what I can say.
Always guidelines are there, but in front of us, patient, we cannot apply the guidelines. They have multiple problems. We face this day in and day out. So I think there are no clear guidelines. I'm not aware of any Indian guidelines also for this, right? There is no, pakka guidelines which covers all aspects. Nothing is there. And these patients have a lot of comorbids, elderly, as we discussed, so much complicated. So I think we should take it as a case by case basis. Let's look at some questions in the chat box. Do you want to take any of those? What are the questions here? So again, what all we have discussed, only this is all other comorbids. A DVT problem, altitude and aircraft travel. I think we discussed that in your slide, right? So everything, all other comorbids, complications of COPD is only adding fuel to the fire. And you need to control each disease separately. Like if COPD is severe, control the COPD. If your DVT is there, treat the DVT. I think that's the, take home message, address each problem. Anything else? Elderly travel, we have addressed that. Absolute contraindication in COPD patients, I think we have addressed that also. So any role for liquid oxygen for COPD in altitude and aircraft? Anybody wants to take that question?
No, basically, the airline authority are usually discourage giving the liquid oxygen.
Correct. So all this supplemental oxygen is dependent on the duration of your travel. You are going for an international travel for 12 hours and things like that. I think in-flight oxygen is preferable than, carrying extra oxygens. So challenges for post-menopausal women with COPD in altitude and aircraft. I think that's a separate this thing. So kyphoscoliosis, patients with kyphoscoliosis, known hypertension on multiple, as we told you, as I think anybody wants to take that, there is a question saying, patients on kyphoscoliosis, known hypertension on tablet, olmesatran, nebivolol, saturation 98% during rest with no respiratory symptoms. Kindly give your valuable advice for long air travel. Anybody wants to take that question?
I think it is in this case that PFT and 6-minute walk test would be more applicable.
Now, control of hypertension. They
Yes.
should BP recording, things like that, cardiac status. I think this is a complicated state. Here you have kyphoscoliosis, you have restrictive as well as an obstructive airway disease. You need to really know the FVC, FEV1, ABG. I think you need to go through a long list before even giving any fitness for this patient.
Yes.
Anything? So yes, Dr.
I think
says pre-travel 4 weeks pulmonary rehabilitation ensures the extra endurance to these type 2 respiratory failure patients. Travel must contain oxygen, BiPAP, and perfect medications are there during the travel. I think very well said, sir. That's what we were discussing. If you have an unsettled primary problem, you have a COPD which is not controlled, you have a coronary artery disease which is not controlled, you have a blood pressure which is not controlled, address the primary problem, stabilize their primary problem, and then I think so very well taken. Pulmonary rehabilitation, anybody wants to comment on that? Do 2 to 4 weeks of pulmonary rehabilitation.
Yes.
One thing is very important because inspiratory muscles are very weak in the COPD patient. If we train them by the proper pulmonary rehabilitation, they may improve their lung compliance and they can less and less. Their exercise endurance is going to be better because that time they have a nutrition, vaccination, vaccinations, and all those things non-pharmacological are going to picture, and they're going to help you very much highly when they are traveling such a high altitude.
By principle, yes, sir. By principle, definitely it will helpful because as Madam is told about that optimization of the pre-existing disease, that is one of the part of that.
Yeah. So I think optimization of the primary disease is what most important. I think we are running out of time. So
I think, ma'am, Vijay sir has posted a question about airlifting of the patient.
Yeah, just saw that. Okay. Airlifting of the patient is separate, I think. You are airlifting somebody, you have everything on the world there. You have ventilator.
You have ambulance aircraft.
You have a luxury ICU inside. Anybody wants to take any comments on that?
Ma'am, obviously that's not akin to a commercial aircraft where the facilities are limited. So if you are airlifting a patient, you have got to lift up sick patients only.
Yeah.
So all the facilities are there. So
airlifting means that patient is sick and then you are arranging a separate air ambulance or something like that, right? Commercial flight and commercial they don't have the facility for all this. And most importantly, nobody is even aware of the problem, the flight attendants or anybody. The COPD patients rarely come to you saying that, no, please reassess me and then give me fitness. Once they travel, once the flight is grounded, they'll create one medical emergency and then only they will come to us. So it's quite...
Second part, ma'am, about airlift. The height is not that much and the pressure is not that much low. That is again benefited for a sick patient also.
Yeah, that's another very good point. You should also remember if your patient is not at all fit for 8,000 feet, they can go for Boeing flights. The Boeing flights altitude is very less, 6,000 feet is the altitude. So you should ask your patient to book a ticket in the Boeing flight, which will cost them some few thousands extra than going on the regular, commercial flight. So that's one point. I think we have come to, we have started descending in our altitude, I think, right?
Madam, one important point, these sorts of commercial planes are just like a private ward, and when you are uplifting any patient, it is just ICU.
Yes.
So patients are being well because they know they may need emergency vasopressors and ventilations, invasive and so with the doctor attendant.
Yes. So shall we conclude? Anybody wants to make any comments? Yeah, I think. Yes, sir.
I think you have made the perfect comment that it is about optimizing the comorbidities apart from the disease itself. With the focus, I think it was a beautiful discussion today from all our each one of us, pointing out the fact that one disease is not a thing to be considered alone. It's the patient by whole and all the comorbidities. I think each has been discussed today, and that is the point that has to be carried today.
Yeah. Thank you to all the wonderful panelists for sharing.
Madam, I would love to congratulate you for such a wonderful moderation of such a difficult topics. Thank you so much.
Thank you.
madam, and
I
all
think,
the panelists
as
are very
Dr.
excellent.
Anand
The
mentioned,
questions
we
are
have read
very
so much about
informative.
air travel in this course. I think search the entire net for the points and things like that. Thank you so much. Thank you to all the wonderful elite panelists. It's a pleasure and honor to be here. As we descend from today's altitude of ideas, one thing is crystal clear. The air may be thin up there, but our responsibility as pulmonologists must remain full bodied and grounded and to cater to our group of patients, to bring relief to them and to have a safe travel. Thank you so much. Thank you for being here. Thank you.
Thank
Thank
you,
you.
ma'am.
Thank you, ma'am, to you.
Thank you, ma'am. Thank you.